So, good evening. So today we'll be discussing about the anesthesia considerations for TAVI. Okay. So what is TAVI? TAVI is basically a transcatheter aortic valve replacement procedure. So why has TAVI become so popular now? This is because severe AS by itself is a very highly morbid and very high risk condition. Okay. And in the past, the management options for severe AS have either been open heart surgery, or if the patient was very considered very high risk for an open heart surgery, you just the patient was just advised optimal medical care to manage the symptoms, and that's it. But now, because of this TAVI which has come up, with while with although it has its own risk benefit ratio, the chances of survival or the chances of a better life in a patient with severe AS has gone up. So that is why it is important to understand about it. Okay, so it broadens our indications of the patient which require which in which AS can be corrected. And as as the evidence for the use of TAVI goes on increasing, it is now being applied to even patients who are in the lower surgical risk profile. So to understand TAVI, we need to understand what aortic stenosis is. Okay, so now in aortic stenosis, as you can see, this is the aortic valve. It is the most easy to identify because of its typical Mercedes-Benz sign. Okay, so even if you see an echo of a patient and you've not seen an echo before, you'll be able to identify the aortic valve, a normal aortic valve, because it is that obvious. Okay, now this aortic valve can undergo degeneration, and there are two main causes for it. If it's a normal tricuspid valve, it could either be degenerative or calcific. Now, in some patients, 1 to 2% of the normal population is born with a bicuspid aortic valve, in which also calcific degeneration occurs, but it occurs at a much younger age. So, you can have patients presenting in the pediatric age group with AS. Okay, so these are the causes of AS. So, it can either be rheumatic, calcific, and bicuspid aortic valve undergoing calcific or degenerative changes. Now, what is the pathophysiology of AS? So, AS, aortic stenosis, is basically an obstruction of your left ventricular outflow tract. Okay, so once your left ventricular outflow tract undergoes an obstruction, naturally the muscle which precedes it, which is proximal to this obstruction, will undergo a hypertrophy because it has to now pump against a fixed outflow. So it has to pump with a lot of pressure. Okay. Now the primary aim of your LV is to maintain the EF, or to maintain the stroke volume. Okay. So it tries to increase its pressure to push against this outflow. Now, in this bargain, what happens is that there are some compensatory changes that the LV starts undergoing, because of which its compliance, elasticity goes on decreasing. So basically, it starts moving towards diastolic dysfunction. Whenever your LV goes to diastolic dysfunction, that is, its end diastolic pressure goes on increasing. Now, with the increase in this LV end diastolic pressure, it reflects back into your LA, and then that reflects back to your pulmonary vasculature. And that is when your patient will start presenting with the symptoms of exertional breathlessness. Okay. Now, once your patient starts becoming symptomatic, it is a sign that the compensatory mechanisms are now beginning to fail. So, if you go through this flow chart, you'll see that first there is just a progressive decrease in the area. Okay, then there is a decrease in the antegrade velocity when the area decreases at least by half, and this is adapted for by the hypertrophy. So, till then, there is compensation. Then, with the early changes, the LV diastolic function gets compromised, but the systolic function is still maintained. So, there will be decreased compliance but unchanged contractility. Now, because of this increase in your diastolic pressure, increase in your LA pressure, these patients can either have atrial fibrillation. So, what happens is when the LA pressure starts increasing, it affects the contractility of the LA as well, and then because of the affected contractility, these hearts or the enlarged LA is more prone to go into AFib. Okay. So as your LV and diastolic pressure increases, the mitral valve annulus also dilates, and the patient can present with a functional MR. So all this without compromising the contractility. This is what are the changes in the early stages when the patient is yet to become symptomatic. And after this stage, once it moves on to the late changes, then you slowly start seeing the symptoms in the patient. Once the systolic dysfunction sets in, then you are on a timeline now. Okay. So the patient will then present with myocardial ischemia or myocardial fibrosis or abnormal wall motion. Okay. Any patient with AS you will see will have ST segment depression. Okay. This is most prominent sign of AS, which is suggestive of two things. One is that there is strain pattern. Second thing is because your LV wall is hypertrophied, okay, and there is so much pressure. So the subendocardium is under so much of pressure that there is subendocardial ischemia. Whenever there is subendocardial ischemia, you will see ST depressions in your ECG. Whenever it is transmural, which is what is seen in your MI, that time you get an ST elevation. Whenever there is strain or just subendocardial ischemia, that is when you will see ST depression. So your AS patient will classically have ST depression on the ECG. Okay. So eventually there is decreased contractility, decreased stroke volume, and your patient presents with failure. Failure is a very bad sign for a patient of AS, okay, because it's completely decompensated. So symptoms indicate that your compensatory mechanisms have begun to fail. Okay, so what are the symptoms that you will get in these patients? We discussed shortness of breath. Okay, shortness of breath is your back pressure changes affecting the pulmonary vasculature. Okay, patient will complain of chest pain. Okay, the chest pain and breathlessness is also a mismatch in your supply and demand. Okay, because now the heart cannot compensate as well to your increasing demand. So when the heart cannot compensate for the increasing demand, it will start presenting with symptoms like chest pain and breathlessness. Okay, whenever the patient tries to exercise, okay, in any form, exercise does not mean running on the treadmill. Okay, exercise for that patient of AS could even be walking a short distance. When the body does that, there is vasodilation. Whenever there is exercise, there is vasodilation. So whenever there is vasodilation, there is a fall in your systolic pressure, when you're in your blood pressure, and now your heart is expected to compensate for this fall by increasing the cardiac output, which does not happen in AS. So now the fall in systolic blood pressure reduces your cerebral perfusion, and that is why these patients will also present with syncope. So these three are the classical signs of AS. Okay, ASD: angina, syncope, and dyspnea. And once this starts, your patient has a timeline of approximately 3 to 5 years before things will go spiral. Okay. So in untreated symptomatic patients, they have a 1 year mortality. 50% patients have an approaching mortality of 1 year. Okay. So that is why a symptomatic AS has to be attended. So eventually the LV becomes dilated and syndromes of your heart failure ensue. So we have covered angina, we've covered dyspnea. This palpitations or irregular heartbeat is because of your enlarged LA, which goes into atrial fibrillation. The dizziness or the lightheadedness is just syncope, basically, when the heart cannot compensate for the required increased cardiac output. And fatigue or weakness, especially with exertion. Again, inability to compensate. So this is your classical triad: syncope, angina, and dyspnea. So how do you assess the severity of AAS? AAS can easily be picked up with the murmur. Okay, so these three symptoms, which are classic, and the presence of the murmur, which is an ejection systolic murmur, helps in the diagnosis of AS. But how do you assess the severity of AS? It is best done by the echo. Okay. So when you do the echo, AS is very simple to analyze like that, because there are very few parameters that need to be confirmed on the echo. Okay. So when we were doing MD, that time we were not we never had to go into the details of echo of AS, but at the same time we were never asked questions about TAVI also. So because now cardiac has become an equally important part of general anesthesia, MD anesthesia, it is important that you all understand the basics of echo. Okay, so that is why I have gone into the details of echo in every lecture of mine. So you all are at least oriented as to what needs to be seen in your echo report when you get a patient with a cardiac condition. Okay. only EF is not important, which is what we used to do in our initial days. EFT can, no problem. But there are other things also which need to be focused on, and that is why I go into the details of echo in all my lectures. Okay.